There are a number of bacterial genera that are very, very small, obligate intracellular parasites. They're generally obligate aerobes. They're most often gram-negative rods. Some of the genera are listed here. They include Rickettsia, Rickettsia, Anaplasma, Coxiella. But really in the US, if you're a human physician or involved in human medicine, most commonly you would see Rickettsia. Those of you, if any of you are interested in veterinary medicine, Rickettsia and Anaplasma are pretty common infections in especially dogs. So the genus Rickettsia is responsible for two kind of major forms of disease, spotted fever and typhus. In general, the bacterium can be found in the cytoplasm of infected cells, which is what we see here. They can dissolve the phagosome membrane, and then again, they'll grow inside the cytoplasm, generally fairly slowly. They replicate every 9 to 12 hours, so faster than some of our Borrelia and Mycobacterium, but slower than a lot of other pathogens. In patients who have spotted fever rickettsia, the bacteria are constantly released from infected cells, so they're constantly being shed and picked up by new cells, whereas the Rickettsia that cause typhus will lyse the infected cells. The first species in this genus that we'll talk about is Rickettsia rickettsii. This is one of the spotted fever rickettsial species, and the disease it specifically causes is Rocky Mountain spotted fever. That's one of the most common spotted fevers. It has a protein called OMP-A, outer membrane protein A, that helps it to adhere to cells so that it can be phagocytized and then escape the phagosome and replicate inside of the cytoplasm. This bacterium generally is transmitted by hard ticks. Remember, we talked about hard versus soft ticks when we talked about the borrelial species. So you may want to go back to the borrelial lecture in order to review the difference between hard and soft ticks. Now, unlike borrelial infection in the ticks, with Rickettsia, we see what's called trans-ovarian transmission. And what that means is that the larval stage, the one that's smaller than a poppy seed, can already have the bacterium. So basically, the ticks can be born with the bacterium. If the mother has it, the babies can have it. So that means larvae can transmit the disease as well. And this is generally going to be found in rodents. And then, of course, if a rodent is bit by a tick and picks up the bacterium and then that tick bites us, then we're in trouble. So Rocky Mountain spotted fever has an average incubation period of about 7 days. The clinical presentation, just like lots of infections, fever, headache, muscle pain, tiredness. It can include nausea, vomiting, and abdominal pain. And what you generally see is a rash in the majority of the patients. You can see that here. That's why it's called spotted fever, because you see a rash all over the body accompanied with a fever. There is no eschar formation, which is different from some of the other rickettsial species that we'll talk about in just a minute. And without treatment, it can have a mortality rate of anywhere from 10 to 25%. The term that you may see here, centripetal spread, what this means is that the lesions tend to be concentrated on the body, and there are fewer lesions on the extremities. So even though this person's extremities look like they have a lot of lesions, you do tend to see even more on the trunk or the main part of the body. The other species that we'll talk about that causes one of the spotted fever type of infections is Rickettsia akari. This causes Rickettsialpox, and it's transmitted by mice generally instead of ticks. The eschar resembles anthrax. So in this case, you do get an eschar. Right here, you see that kind of black necrotic wound. Again, you'll have the abrupt onset of fever, headache, chills, muscle pain, but also photophobia, which means you don't want to be around light. And there's going to be a rash that develops in all patients with a generalized distribution, which means it's basically kind of similar all over the body. It's not on the extremities versus on the trunk in more concentration. It's just kind of everywhere. In this case, so yes means this is the eschar column, so there is an eschar. Mortality is low. There was an outbreak of Rickettsialpox in late 2001 in New York City, and it did cause a lot of panic because the eschar resembles that of Bacillus anthracis. So something you might want to think about is if you had a patient that came into your clinic that had this type of eschar, how could you do a differential diagnosis? What tests could you do to determine whether or not this was an anthrax eschar versus a Rickettsialpox eschar? In the US in 2019, all of the combined spotted fever rickettsial infections, which includes Rickettsialpox and Rocky Mountain spotted fever, there were just over 5,000 cases. And you can see the distribution here. It tends to be kind of clumped in kind of the southeast, a little bit in the Midwest, and then on the East Coast. And that's just because the ticks that transmit, especially Rocky Mountain spotted fever, are a little bit more common there. So here's a clinical case on Rocky Mountain spotted fever, patients who got the infection after working with it in the lab. So that means inappropriate lab techniques. One patient, a 21-year-old veterinary technician, presented to a clinic with complaints of muscle pain and a cough with no sputum, treated with penicillin and discharged. Over the next few days, he developed chills and headache. When he returned to the hospital, he had a temperature of 40 and a rash on his extremities and trunk. Intramuscular tetracycline was started, but he remained febrile. The rash evolved to petechia, so broken blood vessels on his trunk, his extremities, and the soles of his feet. He developed effusions in the lungs. They began intravenous tetracycline. Over the next 2 weeks, the lungs resolved. The patient made a slow but uneventful recovery. Although he was not working directly with the bacterium, he had visited a laboratory that was processing it. So that laboratory had really poor standards. This patient illustrates the characteristic presentation of Rocky Mountain spotted fever, headache, fever, myalgia, and a rash that can evolve into a petechial or spotted rash. So it's important to think about, why did the penicillin therapy fail here? We will talk about penicillin and how it also is not a great treatment for chlamydia, and maybe that'll help you make the connection as to why for this infection and for other infections, penicillin may not be a good choice. So with Rickettsialpox, there were 18 patients with Rickettsialpox in New York City during a 20-month period after the anthrax bioterrorism attack in the fall of 2001. The patients presented to the hospital because they had a necrotic eschar and thought to have cutaneous anthrax. The patients also had a fever, headache, and rash. Many patients also complained of muscle pain, sore throat, joint pain, GI symptoms. Staining of the eschar and skin biopsies confirmed the diagnosis of Rickettsialpox and not cutaneous anthrax. So what did those biopsies look like that showed Rickettsia versus Bacillus anthracis? These patients illustrate the diagnostic difficulties of recognizing uncommon diseases, even when the clinical presentation is characteristic. So for diagnosing Rickettsia, microscopy and staining can be used to visualize the bacteria in tissue specimens. Nucleic acid tests are just not sensitive enough to detect if you have a blood sample. Culture is difficult, as you might imagine. It's an intracellular bacterium, so you have to be proficient with tissue culture or eggs. It can be grown in eggs. Most common for diagnostics, again, microscopy and staining, but also Western blots against LPS and other outer membrane proteins. And treatment would be with doxycycline, fluoroquinolones, or chloramphenicol.